Good morning, ladies and gentlemen. Please fasten your seatbelts as we continue our journey with the ophthalmology clerkship video sessions. Today, we will be talking about open angle glaucoma, which is our final differential in the theme of gradual painless loss of vision. Our laundry list today includes the definitions of glaucoma. We will also talk about the triad of glaucoma, which is rather important, and we will spend a bit of time on it, then patient presentation and management. Once we know the triad, presentation as management isn't that hard to comprehend, although to follow it practically is another set of issues altogether. So this is what glaucoma has been defined as for the last several decades. It is a progressive optic neuropathy with characteristic visual field defects in which intraocular pressure is a significant risk factor. And that is it. Intraocular pressure does not define glaucoma. The definition that most people follow and probably is written in many texts that glaucoma is rise in intraocular pressure is dead. It's buried. It's gone. We have said a prayer for it. It's no more. Glaucoma is an optic neuropathy with characteristic visual field defects in which intraocular pressure is a significant risk factor. It's the leading cause of irreversible blindness all over the world and the known universe. And what's more, we have a new definition, and this is more appropriate. And maybe in the next 5 or 6 years, the definition at the top would be dead and buried as well. So the newer definition says that glaucoma is a multifactorial optic neuropathy with characteristic loss of optic nerve fibers. We talk about which nerve fiber those are, which is usually but not necessarily identified on visual field exam. So now we have even moved further than what we used to say with characteristic visual field defects. We say that we might not even see those defects and still have glaucoma because the neuropathy that defines glaucoma still exists. And this has happened because we have newer imaging techniques in the form of OCT that has made this possible to detect really early damage that tells us, hey, glaucoma is here, but we don't see it on a visual field. So this definition is something that's coming up. So forget the definition that says glaucoma is rise in IOP. It's gone, it's dead, it's buried. Please don't say it, irrespective who asks. This is what glaucoma is at the top, and this is what glaucoma is going to be in the future. The reason we keep calling it open angle because the anterior chamber angle is open. We'll see what that means. And the reason IOP is a risk factor is because the changes we see in glaucoma can take place when the IOP is normal. Conversely, we see no changes of glaucoma when the IOP is high. Thus, IOP is a risk factor. There are certain facts that we need to go through. Since we're not going to talk about the disease immediately, we need to talk about the triad first. So here's some information to keep you interested in the proceedings. It's a bilateral disease. It can be congenital, it can be acquired, and IOP is a risk factor. It causes a gradual painless loss of vision, which is the bane of this disease. We'll see why that is in a bit. And visual acuity is affected very late, and that is also why it is such a bane. Simply because if it was a problem with visual acuity, the patient would turn up, hey, I can't see properly. Visual acuity is affected very late in the disease, very, very late in the disease, towards the end of the disease. So it's not a very good measure of where your disease is going. It is mostly a disease of visual field. It can be because of a primary pathology, which is the most common type, in which the trabecular meshwork, the drainage tissue in the angle, is affected. Or it can be because of a secondary pathology in which there is something going on with the trabecular meshwork because something else is going on in the eye. For example, there is inflammation within the eye. There was, for example, a tumor whose cells have sort of blocked the drainage pathway. The acquired primary open angle glaucoma has a very significant asymptomatic period, which could be up to a decade or longer. And this is the problem because it's a gradual disease, it's a painless disease, it's a disease of a visual field. So it remains asymptomatic because, as we shall see, the initial period in which the disease remains undetectable, even on visual field testing, is significant. And beyond that, we have a significant period in which you might start getting defects on visual field testing, but the patient is unaware of it. Thus, screening is essential to catch this disease early. Screening is very, very important in glaucoma, just like it is in diabetes. The secondary variants might have an antecedent history of pain in the eye or a red eye, but the glaucomatous process that produces this gradual painless loss of vision still remains painless, and still that process is asymptomatic. So now that I have seeded some information in your brain to keep you intrigued, let's talk about our triad. And the first of the trio is the intraocular pressure. This is simply the pressure within the eye, and it is generated because of the production and drainage of the aqueous humor. The production is slightly more than drainage, thus the pressure within inside the eye. And before you ask, no, vitreous has no role in generating intraocular pressure because vitreous is a formed body. It is of a fixed volume. It does nothing for intraocular pressure. The aqueous is generated from the ciliary body, the part of the ciliary body which has fold. It is called pars plicator, and it travels between the iris and the lens and then into the anterior chamber. The anterior chamber is the gap between the iris and the cornea and drains into the anterior chamber angle. Now, 90% of your aqueous, which is this blue dot right here, drains through the trabecular meshwork. There is 10% that drains through the uveoscleral pathway. So let's just highlight these two. The white line is the trabecular meshwork pathway, which is the major pathway. The red line, which deviates from here, shows the uveoscleral pathway or the minor pathway as the aqueous is reabsorbed into the uveal tissue and then out of the eye. There are drugs that use the uveoscleral pathway, thus it is important to know both of these mechanisms through which the anterior chamber, through which the aqueous is drained. What you might be interested to know is that the canal of Schlemm lies outside of the anterior chamber angle. The aqueous does not directly go into the canal of Schlemm. It has to pass through this rather important structure, the trabecular meshwork, because this is the structure that's slowing down the flow of aqueous so that some pressure can be generated in the eye. So what's the normal level? The normal level of intraocular pressure is between 12 and 21, quite a large range, and that large range simply exists because the intraocular pressure varies by time of day and your activity as well. And this type of glaucoma is called open angle glaucoma because the aqueous, as you can see from this diagram, has access to the angle. It can reach the trabecular meshwork. There is another type which is called angle closure, which we'll do when we do the red eye, in which because of one of the reasons is that the iris moves anteriorly and blocks the access of the aqueous to the angle, which is then called angle closure. But in this case, the aqueous can reach the anterior chamber angle pretty easily, thus open angle glaucoma. So before we talk about anything else, how do we measure intraocular pressure, we need to understand that this angle that we keep saying, we can't see it normally. So when you use a torch or a slit lamp, this is what you see. Between these two white circles is the area of the angle. Remember, the angle, as we decided here, is between the periphery of the cornea and the place where the iris attaches to ciliary body right here. So these dotted lines is showing you where the angle is. And this part, it's at the very periphery, as you can see. This is the sclera, this is the cornea, this is the limbus. Limbus is the transition between the sclera and the cornea, and this is where the angle is between these two white lines. And you normally can't see it because of total internal reflection of light at this point. If you want to know what total internal reflection of light is, you can Google it, or you can just rely on your memory because you did it way back in school. So we need to change the refractive index of the cornea in order to overcome this total internal reflection so that we can actually visualize the angle. I think that is done by a lens called a gonioscope lens. And the process is called, the procedure to view the angle is called gonioscopy. This is how a gonioscope is put to the eye. It has these mirrors through which you can look at the angle. There are various types of gonioscopes. Gonioscopy is not something we expect undergraduates to do. So this information is here to assist you in understanding how an angle appears when we show it to you in pictures. You have to learn to appreciate the angle as you see it in pictures. That is sort of necessary, although you don't have to do gonioscopy yourself. So this is the view you get from a gonioscope. That's why I was saying you need to sort of understand how this happens, because really, what am I looking at? That's the first thing that I thought when I saw this picture way back in school. But let's try and see what we are looking at. Imagine that you're standing on the lens, in the middle of the lens, over the pupil, and you're looking at the angle. So I'll show you this animation which makes this clear. So this is an eyeball, and what we are going to do is going to cut the eyeball because we need to reach the lens and the center of the pupil. So we are traveling this dude who is us, is traveling into the eye. Here we go. We're going to start traveling into the eye. Slowly but surely, we'll get there. And this is our point of view, this arrow, which is showing you where we are looking at. And as we get closer and closer to the angle, as we'll see right now, we are standing on top of the lens, about at the middle of the pupil. Here we go. So we are nearly there. Our dude is a little slow. Here we are. So this is where we stand, and this is the view we get. So imagine that you're standing on the lens at the middle of the pupil and you're looking at the angle. So this is the view you get from a gonioscopic lens, and all you see are these alternating lines which tells you various structures of the angle. It's amazing how people who first saw this were able to figure out what they were looking at, but we will try and see what those structures are which make up the angle while doing gonioscopy. So this is an artist's impression on the left, and this is the picture we saw in the previous slide. And these are the various structures that you see, but not all of them make up the angle. Angle structures begin from 3, 4, 5, and then 6. So let's see what we are looking at. So this structure right here, 1, is the pupillary border, indicated by 1 here. This is not a part of the angle. These are just the structures that you see when you do gonioscopy. This is 2. This is the peripheral iris right here. This also is not a part of the anterior chamber angle. 3, which is between 2 and 4, obviously, this area right here is called the ciliary body band. This is the part where the iris attaches to ciliary body, and this is the first boundary of our anterior chamber angle. Then we have 4, this white line right here, which is called the scleral spur. Since sclera is white, this line, if I can remove this indicator that I made, is also white. Now you see right here, this whiteness sort of disappears because this is an Asian eye which has a lot of pigment. So this line is sort of obscured here, but this is what the scleral spur is. Beyond this, we have the trabecular meshwork, the most important structure, the structure that helps aqueous get out of the eye. And this is number 5 right here. And then number 6 is Schwalbe's line. Remember, the angle was between the root of the iris and the cornea, as we saw in the picture in which we were showing you the path of the aqueous humor. So this is the anterior most boundary of the angle, which is the Schwalbe's line. The Schwalbe's line is basically the termination of corneal endothelium. So beyond this, you would have the sclera starting, because this is where the cornea ends. And remember, where the cornea ends, the sclera starts, and we are looking at the posterior aspect of the cornea, the part of the cornea that faces the anterior chamber. Anterior chamber is the gap between the cornea and the iris. So structures 3, 4, 5, and 6, this, and this, these are the structures that make up the anterior chamber angle. Yes, I know there are 4 structures, but only one is of importance as far as aqueous is concerned, and that is number 5, the trabecular meshwork, because this is the structure that helps drain the aqueous humor out of the eye. So structures 3, 4, 5, 6 are the ones that help drain the aqueous out of the eye, of which number 5 is the most important to us because that is the structure that helps aqueous get out of the eye. So this is how we decipher the view that we get from the gonioscopic lens. We'll talk and see more about gonioscopy and the view that we get from this when we talk about angle closure, because in open angle we know that the trabecular meshwork is visible, it's seen. But when we talk about angle closure, because of the movement of iris, as we saw again in the diagram in which we showed you the production and drainage of aqueous, the anterior movement of the iris or displacement of the iris can actually obscure the trabecular meshwork, impeding the drainage. So gonioscopy is more important there. We'll talk more about it there. It's put here to complete the discussion on aqueous humor and intraocular pressure, because you need to know how it gets out of the eye and how we view this trabecular meshwork structure and why it can't be normally viewed because of total internal reflection. So now that we know how aqueous is produced, it's time to learn to measure the intraocular pressure, and we have 3 different methods for you. Number 1 is digital tonometry, which, sorry to disappoint, does not involve computers but the digits on your hand, i.e. your fingers. Next is contact tonometry, of which one is called Schiot's. It's no longer done. I'll just show you a picture so that you know what it looked like. Consider it a dinosaur. Then we have Goldman applanation tonometer, which is the current gold standard, first choice standard. I don't know which of these terms appeal to you, but just remember one of them. Don't say Shearts is the thing to use. Shearts is a dinosaur. Shearts is dead. But you need to see this because there are museums of natural history, so there has to be some museum of ophthalmology history. Then we have a non-contact method, which is one of them is air puff, and that is basically a non-contact form of applanation. I'll tell you what applanation is. So digital tonometry is very simple. Use your fingers. We have an entire video on this clinical skill. See that. Basically, what you're doing is palpating the globe and seeing on palpation, is it like pressing your nail, which would be a hard eye, pressure is high, or is it like pressing the pulp of your finger, that would be a soft eye, normal intraocular pressure. This is Shearts. Shearts is dead. So this is the gold standard, the current standard. This is called the Goldman applanation tonometer. And what it does is it applanates the cornea. Applanates means to flatten. When you applanate something, you're flattening it. So what this does is it flattens the cornea by pressing against it. This bit of the tonometer, which is called the tonometer head right here at the top, which is on this sort of a metallic rod. And when the force applied by the tonometer equates to pressure inside the eye, that reading is taken and that tells you the intraocular pressure. So since this is going to touch the eye, you need to put a drop of anesthetic in the eye. And to view better the Myers, which are actually telling you the measurement of the pressure, we put some dye onto the cornea, which is fluorescent dye, so that we can see these Myers. The position of the Myers is actually telling you that the force applied by the tonometer head is now equal to the pressure in the eye. And how do they tell them? Well, you keep moving this dial and you wait for the Myers or the arcs that are in the head of the tonometer to just overlap. I'll show you a video, just look like this. And then you take the reading of the dial, multiply it by 10, and that tells you the intraocular pressure. This instrument is mounted on a slit lamp, which looks like this, and this red arrow is showing you the instrument. Let's see a little video of how this is done. This is the slit lamp, this is the tonometer. Again, we put some dye in, and it's approaching the eye, and it's going to touch the eye. And these are the two arcs of the Myers, and the dial is moved until they're just overlapping. And when they're just overlapping, yeah, there we go, this position. So at this position, we take the pressure, which is, this is 1, so multiplied by 10, that is multiplied by 10, so 1 becomes 10. This is 12, this is 14, so it's just beyond 14, so it's 15. So if I were to show you a picture of how this would look like, it would look exactly like this. This is one of the arcs, this is the other of the arcs. We have moved it to a point where the arcs are just overlapping. That means the force being applied by this head equates to the pressure in the eye. We take this reading, multiply it by 10, and that's our intraocular pressure. This is the gold standard, the in standard, the thing that people do. Shearts is dead. This is non-contact tonometry or air puff tonometry. It is called non-contact because this is applanating without any physical contact. So this is a very good screening tool. This is not a good tool to monitor the progression of the disease or to base your management on. And the reason is it's not very accurate when the pressure is very high or very low. So you can't use it for management because you're not getting a very accurate reading. But it's a very good screening tool. It's a good screening tool because you don't have to put a dye or an anesthetic in. You don't have to clean the tonometer head every time you use it. You can use it for a lot of populations. Sit the patient down, take the reading, bring the next patient in. And remember, screening is very important in glaucoma because by the time that the patient knows it's glaucoma, it's already been a decade or longer. So screening is really important. How this works is basically uses a jet of air to flatten or applanate the cornea, and these two sensors basically pick up the flattening, and it takes the pressure or the force by which air is being released from this position right here, and this is how it's really done. So the reason I've kept the volume up is because you need to hear the sound of air coming out. We have a advanced version of this tonometer in our OPD. It looks very much like an autorefractor. Bring it close to eye. That's the air coming out. It automatically lets the air out from here, which flattens the cornea and it takes 3 readings per eye and gives you the average. So all the computations and sensor stuff, these are the sensors that are measuring the flattening, and this is the point where the air comes out. It is Pakistani, so as you can hear Pakistan being mentioned. There we go, 3 readings, then a printer, which is very noisy. Right eye 13, left eye average 11. The benefit, no contact, no cleaning, no dye, no anesthetic. Good screening tool. But the gold standard is Goldman applanation tonometer. Just remember gold from Goldman. That's the easiest way I can think of. So now that we have completely talked about intraocular pressure, how it is produced, how it is measured, let's move on to triad number 2, which is optic disc cupping. It used to be called optic disc cupping, but now more appropriately it's called retinal nerve fiber layer loss, which is still optic disc cupping. It's just more appropriately termed retinal nerve fiber layer loss because now we have better ways of measuring this. So let's see what this is all about. Before we actually go on and talk about optic disc cupping, let's learn something about the optic disc. So the optic disc or the optic nerve head, both of them are the same thing, is the beginning of the second cranial nerve, the optic nerve. It's the part of the optic nerve within the eye, the intraocular portion of the optic nerve, and this black square is indicating where it is, and this is a cross-section magnified view of the optic nerve head or the optic disc. The reason this diagram is here is to show you that the optic nerve head or the optic disc is just not a flat structure, it's a 3-dimensional structure. It carries visual information out of the eye, so it's composed of neural elements, and those neural elements have to travel through the entire thickness of the retina first, then the choroid, then the sclera. So that is happening because the optic nerve or the optic disc begins towards the vitreous side, and it has to traverse the entire retinal thickness and then the choroidal thickness and then the thickness of the sclera to get out of the eye. Let's magnify this to get a better understanding. So this is the choroid, and these are the 10 layers of the retina. You know the retina has 10 layers. I'm sure you did. More detailed here, less detailed here. These are the important bits. These are all the 10 layers. And this layer, the nerve fiber layer, is actually the layer that's closest to the vitreous, and this is the layer that actually forms the optic disc or the optic nerve head. Right here, as you can see, nerve fiber layer, we'll see what this nerve fiber layer is in a bit, which is a part of the retina, also continues on at the optic nerve head as a component of the optic nerve. And as you can see, it has to travel, these nerve fibers have to travel all the way out of the eye by traversing the entire thickness of the retina first, then the choroid, and then the sclera, as shown here as well. Let's just have a very bird's eye view of what happens when light falls on the retina. So light falls on the retina, excites the photoreceptors, and then the visual information has to travel all the way back, yes, upwards, and then through the nerve fiber layer, and then back again to the eye. So you can see that the light has to travel all through the 10 layers of the retina, reach the photoreceptors. The photoreceptors have to send the electrical signals up all the way back to the nerve fiber layer, which has to travel all the way out of the eye back again. So it's a lot of back and forth, but this is how it is. This is how it is anatomically laid out, and this is how it physiologically functions. And since it works, I'm sure this is the best evolution could do for you. Or whatever might you believe, religion, evolution, science, whatever takes your fancy, suits your fancy. This is how the optic disc or the optic nerve head really appears, and it has 3 distinct structures to it. One is the margin, which is the boundary between the retina and the optic nerve head or the optic disc, so this part right here. This is the part where the nerve fiber layers from the retina continue on into the optic nerve head or the optic disc. The second part is the central part, which is shown as white here, which is called the cup. The cup has no neural elements. It only has a lot of glial tissue and the central retinal vessels that are passing in or out of the eye. So where is all the meaty stuff? Where is this nerve fiber layer? Well, that's located in the rim. The rim is between the boundary of the cup and the boundary of the optic disc. And this is where you have the nerve fiber layer. This nerve fiber layer, as you can see, is actually formed by the axons of ganglion cells. These, what's the color? Yellow colored cells are the ganglion cells, and their axons form the nerve fiber layer. And these axons of ganglion cells i.e. the nerve fiber layer, exits the eye through the rim of the optic nerve. The reason they appear pink is because right now they are non-myelinated, and thus you see the reflection of the blood vessels that supply this neural tissue. And they would remain non-myelinated until they cross the lamina cribrosa, which is the part of the sclera which has all these openings through which these nerve fibers exit the eye. Beyond the lamina cribrosa, you have myelination of these nerve fibers. The other thing to remember is these fibers are not covered by neural lemma, so they're not going to regenerate once they have sort of died off. So the important bit or the important structure within the optic disc is actually the rim, because that's where the neural tissue is. And this neural tissue is basically the continuation of the nerve fiber layer of the retina, the 10th layer of the retina, out of the eye. And the nerve fiber layer is basically axons of ganglion cells. So let's see how this nerve fiber layer loss occurs. And for that, I'm going to draw this diagram, which is going to be representative of the cross section we saw before. So we have our three layers, the outermost layers, sclera, choroid, and then we have the RPE, which is the non-neural layer of the retina. Remember, the retina has 10 layers, 9 neural, 1 non-neural, which is the RPE. And as we saw in the previous picture, the pathway of signaling begins when light falls on rods and cones, the photoreceptors. So the first structure that actually responds to light and starts off the signaling process is your photoreceptors, and which is shown right here as rods and cones. These are going to send their signal to the first order neuron, which is the bipolar cell. Remember, it takes 3 neurons to get the signal from the sensor all the way back to the central nervous system. So our sensor here is a photoreceptor. Our first order neuron is a bipolar cell, which is shown in green here as well. These are they're called bipolar because they are sort of have 2 poles. They're going to send their signal to the second order neuron, which is the ganglion cell, shown as yellow here and brown here. Couldn't use yellow because couldn't see yellow. And as you can see, as I'm drawing these sections, I'm leaving the also indicating where the optic nerve is. And remember, optic nerve has to travel through all of these layers because it needs to get out of the eye. We saw this back and forth in the previous slide. So from the bipolar cells all the way to ganglion cells, and these ganglion cells have very long axons. In fact, these axons are going to go all the way to the lateral geniculate body, and they have their own layer within the retina, which is called the nerve fiber layer. And the nerve fiber layer is shown right here in yellow, right here. These are basically really long axons of ganglion cells. And these nerve fiber layers run along the surface of the retina. The retinal picture that you see, the topmost neural layer towards the vitreous, the one that you can see through your ophthalmoscope, is basically the nerve fiber layer. And these nerve fibers are running on the surface of the retina, and they exit the eye through the optic nerve head or the optic disc, just like shown here. And see how they have to travel all the way back through the entire thickness of the retina first, then the choroid shown in red, and then the sclera to get out of the eye. So this is the back and forth. The light travels through all of the layers of the retina. Then the signaling has to go all the way to the top again, and the signal has to travel all the way to the bottom via the axons of the ganglion cells. So you see how long these axons are? They start off from the nerve fiber right here, and they're going to go all the way back to the lateral geniculate body, which is the location of the third order neuron. But that's not of interest to us. Our interest is this nerve fiber layer, because remember, when we started talking about the second triad, cupping, we also call this as the retinal nerve fiber layer loss. So something is happening to this layer, the nerve fiber layer, which is sort of responsible for the entire issue with glaucoma, because loss of neurons implies loss of signaling, which implies loss of vision. See how important this one event is? So how do we start losing these neurons? Well, if you see this picture right here, where these axons of ganglion cells enter into the optic disc or the optic nerve head, there are these 4 distinct quadrants. And these fibers that you see from the superior and inferior area of the retina, which are called the superior arcuate and the inferior arcuate fibers, as they enter into the optic disc, they are very densely packed. There are a lot of fibers going into an area which is not much. It's like, you have this sale at a women's fashion place and everybody wants to get in. This is what these superior and inferior arcuate areas in the optic disc, as highlighted by these white outlines, are. As opposed to these areas, the papillomacular bundle, which is carrying information from the fovea and the macular area, and the nasal fibers coming from the nasal retina, they have a lot of room to wiggle about. Consider this a sale in men's store. You can get in and get out, no problem. But the problem areas are these, the superior inferior arcuate areas on the optic disc or the optic nerve head, because the fibers are really densely packed. And this is where the problem area is theorized to be. Remember, well, we haven't talked about this. We don't really exactly know how glaucomatous damage starts. There are theories about it. We're going to talk about two of the most important theories in the next slide. Let's talk about the theories. There are two theories. And before we get to the theories, let's take the optic nerve head or the optic disc out to make it more prominent. By out, I mean do this. So I put the retinal layers and the choroidal and the scleral layers in the background and made them sort of lighter, and I've taken the optic nerve head or optic disc out. And as I said before, the optic nerve head or the optic disc is not a flat structure. It is a three-dimensional structure. It has a depth to it. It begins at the point where the nerve fiber layers enter into it, which is the layer closest to the vitreous, and it has to travel through the entire thickness of the retina first, then the sclera, then the choroid to get out of the eye. So the entire intraocular portion of the optic nerve is the optic disc or the optic nerve head, and it is represented here. So what are the two theories? Well, the first theory is that no matter what level of intraocular pressure, be it high, be it normal, it's always compressing on these nerve fibers in the disc. And remember how we talked about that these superior and inferior arcuate fibers are densely packed? The effects of the intraocular pressure are felt here first, simply because there are a lot of things and they are compressed together, and then you're pressing on them with intraocular pressure. It's like, you have doors to a mall which has just opened and there are people getting in, and then there are guards trying to close the door to limit the amount of people getting in. So you have two problems: pressure of the people and pressure of the doors closing. Here you have pressure of such a lot of densely packed fibers and the pressure of the eye compressing upon things that are already pressed. The second theory is called the vascular dysregulation theory, and it states that as these fibers are traveling in the optic nerve head on the optic disc, they become ischemic. And again, the effects of ischemia would be felt most where you have the most densely packed fibers, i.e. the superior and inferior arcuate fibers. So either because of these two reasons, theories, pressure theory or the vascular dysregulation theory, you're going to start seeing loss of retinal nerve fibers within the rim of the optic disc. Remember, they travel in the rim. The central cup has no neural tissue, only transmits central retinal vessels. So you'll start getting damage as shown here by this white area, and this damage occurs in the inferior, the superior poles first, because this is where most of your densely packed fibers are. And this nerve fiber layer loss that is now detectable by OCT even before it becomes visually obvious. So before you can see cupping, you can detect cupping by doing OCT, and that is why the change in definition from the currently established standard, which says characteristic visual field effects, to characteristic loss of optic nerve fiber layer, i.e. these nerve fibers, in which visual field effects are not always detectable, because visual field effects come way after this, after you have lost about 50%, between 30 and 50% of these nerve fibers in your optic nerve head or your optic disc. So that was one problem. The other problem was cupping. Yeah, you can see before you lose so many fibers, but even very initial loss can be detected by OCT imaging even before you can see cupping with your eye. Thus, cupping is now more appropriately referred to as retinal nerve fiber layer loss. It is still called cupping when you see it, but before you can see it, it's just retinal nerve fiber layer loss. And now we have the technology to see it through OCT imaging. So let's see how does this retinal nerve fiber layer loss becomes cupping? How does it manifest into something we can see? So let's bring this back here to our retinal layers. And remember, this is the area of the retinal nerve fiber layer loss within the optic nerve head or the optic disc, to be more precise, in the rim of the optic nerve head or the optic disc. This is the area of the loss. And because these fibers lack neurolemma, once they die off, they are going to degenerate all the way back to their cell body. And that would imply that these ganglion cells can no longer transmit signal from their bipolar cells because they don't exist. And since we have lost nerve fibers within the optic disc rim, this place of loss has to be taken up by something, and it is taken up by glial tissue from the disc. Thus, the size of the cup within the disc increases because that's where the glial tissues are, and that is what is cupping. So either because of vascular dysregulation or high pressure, you start losing nerve fibers within your rim of your optic disc, and that usually happens in superior inferior arcuate areas because they are most densely packed. As you lose these nerve fibers, it leads to a process of degeneration all the way back to the cell body because these nerve fibers don't have neurolemma, which can assist in regeneration. And as these fibers are lost within the rim of the optic disc, something has to take the place of the loss, and that is the glial tissue from the cup. So the size of the cup increases relative to the size of the rim, which is then called cupping. Because the size of the cup is increasing, the size of the rim is decreasing because the disc cannot get out of its margin. So this is what cupping is. And initially, when you start seeing cupping, it's vertical. It does not expand concentrically, it starts off vertically, and the reason you can see clearly from here is because these superior inferior arcuate fibers die off first because they are more densely packed. And later in the disease, yes, you have loss of papillomacular bundle as well as nasal fibers. And as we shall see later, just a bit later when we talk about visual field effects, how that happens. But initially, cupping is vertical, and it's like these. You have these notches right here, and these notches represent to loss of the nerve fiber layers in the superior and inferior arcuate areas because these are most densely packed within the optic disc or the optic nerve head. And this is what cupping is. So cupping is a manifestation, a visual manifestation of retinal nerve fiber layer loss, but you can now see retinal nerve fiber layer loss even before you can visually see by use of OCT. And that is why that subtle change in definition, as we saw when we talked about the definition change. The dead definition is rise in pressure. The invoked definition is optic neuropathy with characteristic visual field defects in which intraocular pressure is a risk factor. The changing definition says it is a multifactorial optic neuropathy with characteristic loss of retinal nerve fiber, which may or may not be detected on visual fields. Why are the changes happening is because now we can actually see loss of nerve fibers even before they can manifest as visual cupping and way before they lead to production of visual field effects. We'll come back to visual field effects in a bit. So again, cupping tends to be vertical. Let's put some word against cupping to define it. Cupping is simply an increase in dimensions of the optic disc cup to the dimensions of the optic disc. And that is happening because the rim is shrinking, and as the rim shrinks, its place is taken by the cup. So in very simple words, since the margins of the optic disc are fixed, if the cup size is increasing, the rim size is decreasing because the margins are fixed. It is symbolized as cup disc ratio, CDR, CD ratio, or C/D ratio. And as we have talked about before, cupping was once a standard which defined glaucoma, and it still does it. It still does it. But since now we have more modern ways of looking at retinal nerve fiber layer loss, and remember, it is this nerve fiber layer loss that leads to cupping, we can see this retinal nerve fiber layer loss, RNFL, by OCT prior to visually being able to see cupping. And cupping occurs before visual field loss does. These things are important because this helps us identify the disease quicker, which helps improve the quality of life of patients better. And this is really important for a disease like glaucoma, where the symptoms occur a decade or more after the damage starts. And the better our screening tools are, the better we can help our patients. Thus, screening is so important for glaucoma. And obviously, until you control the disease, the neural tissue would continue to get lost because of the either the vascular dysregulation theory or the IOP theory, which theory or both of these theories or any one of the other processes that we don't even know about continue unabated, the neural tissue would be lost. And as long as the neural tissue is being lost, the cup disc ratio would continue increasing. So what is the normal cup disc ratio? Well, the normal cup disc ratio has been defined to be between 0.3 and 0.4. So that would imply that these dimensions of the cup is about a third of the dimension of the disc. In other words, I can squeeze in three discs. I can squeeze in three cups in one disc because the size of the cup is about a third of the size of the disc. And we are measuring vertical diameter, although we can measure vertical and horizontal both. Vertical is more important because remember, cupping starts off vertically because it is the superior and inferior arcuate fibers within the rim of the optic disc that starts getting damaged first because of increased density of their packing or the closeness or the number of fibers in those zones, simply put, because they're so densely packed together. They're the first to feel the effects of pressure or vascular dysregulation, and they die off first. Thus, your cupping starts vertically. And that is why we pay more attention to the vertical diameter. Although you can measure both vertical and horizontal, there's nothing stopping you, but vertical diameter is more important than horizontal. How do we see this, visualize this? Well, the oldest method is ophthalmoscopy or using one of these lenses. But this is very subjective. I can draw a picture and I say a cup disc ratio of 0.5. Another ophthalmologist will say, no, this is 0.6. So a better way is to take photographs and measure, and this camera is mounted on a slit lamp or any other instrument that can actually take a picture. We have fundus cameras that are special equipment just to take pictures of the retina. And the best part is you can take these pictures over time and review the progression of the disease. The best way or the most modern way is using optical coherence tomography, and that is using light to measure the thickness of the retinal nerve fiber layer. And remember, as we have talked about before, OCTs can pick up loss of nerve fiber layer prior to you can see cupping using photographs or ophthalmoscope, i.e. prior to using your eye. And that is why OCTs are becoming so popular in ophthalmology and are basically overtaking other examination and investigation aids. As we already talked about about OCT when we were talking about diabetic retinopathy. So OCTs are the examination or investigative technique in ophthalmology. So this is, just looking at a photograph, taking a scale and measuring the cup disc ratio. So in this case, and these are not drawn to scale, by the way, the dimensions of the cup is about 2.2. The dimensions of the disc is about 2.2 in blue. The dimensions of the cup is about 1.1. So the cup disc ratio is about 0.5. So the idea is you can take pictures over time and see how cupping progresses in an uncontrolled disease. So here you can see notching. And remember, cupping of the disc usually begins as notching vertically simply because of the initial damage to the superior and inferior arcuate fibers because they are so densely packed in the rim of the optic nerve. The disease process continues, the cupping continues to expand, and you can see 0.6 still more vertical. At 0.7 it becomes more concentric, more symmetrical. So that means at this point in time, your papillomacular bundle as well as your nasal fibers are now getting damaged. And it is at this point and maybe 0.8 where your visual acuity starts getting affected. Because remember, visual acuity is served by fovea, and the fibers coming from the fovea were the papillomacular bundle, and they don't start getting affected initially. It is only this late into the disease that you have the foveal fibers or the papillomacular bundle getting affected. Thus, visual acuity is not a good guide to where your disease, where glaucoma stands, because visual acuity is affected very late into the disease. We'll talk more about this when we talk about visual field effects in just a bit. So this is a fully cupped disc. This is the end, and I've shown the disc margin in black and the cup outline in red, but you can't see the two lines separately. They're just one line because the entire disc is now a cup. All of the neural elements have been lost, and this is the end stage. This is the goodbye stage. Your optic disc has burnt out. It says sayonara. Rest in peace. This is OCT, and this is the up and coming way of doing everything with glaucoma. What it does is, and we've talked about OCT before, it generates images based upon coherence and interference of light. We talked about it when we were talking about diabetes, and we were specifically looking at the foveal area. Now we are looking at the optic disc using the same principles. The good part about OCT is that it can pick up glaucomatous retinal nerve fiber layer loss even before cupping is visible. And that is very important because it helps pick out patients even earlier than we were able to before. Before we were relying on cupping or visual field effects. Cupping could be seen before visual field effects. So good ways of picking up cupping was one way of early screening. Now we can even pick up retinal nerve fiber layer loss before cupping occurs. We can pick up patients from the general population by screening them and treating them earlier, because our machines can now tell with a lot of confidence that what we are looking at right now is actually glaucomatous loss. Because nerve fiber layers within the optic nerve can be lost for many reasons. We've already talked about one of those diseases very clearly when we talked about retinitis pigmentosa, in which the disc was getting pale, which implied that yes, the fibers within the disc were dying. That is also a type of retinal nerve fiber layer loss, which is not glaucomatous. So these machines now with newer software can tell you, yeah, the pattern that you're looking at pattern of nerve fiber layer loss is glaucomatous. So even before you start seeing the characteristic optic neuropathy, i.e. cupping, you can now with OCT pick up retinal nerve fiber layer loss because of glaucomatous disease process. And that is great from a screening point of view. So how does this work? Well, look at this is a picture of the cupping. This is a very late, obviously late in the disease, and I've just shown this to accentuate or to really show you what cupping would appear on in OCT. So these are the disc margins, and I'll draw them on the picture as well as the OCT. These are the margins of the optic disc. These are the margins of the cup, and between the cup and the disc is the rim right here. And the machine can measure this rim. And not only can this measure the size of the rim, the thickness of the rim, it can also tell you, yes, this pattern of loss of the rim or the retinal nerve fiber, because remember, it's the rim in which you have your retinal nerve fibers. This loss of rim is actually because of glaucoma. And that is what's so good about these modern software solutions to OCTs, which can actually tell us, yeah, you're looking at nerve fiber layer loss, which is glaucomatous. And as the machines improve and the software improves, OCT is probably going to take over the entire management protocol of glaucoma. Right now, we are still reliant on visual fields, but OCT is really promising in this regard and up and coming in management of glaucoma, and in fact, other retinal diseases as well, as we've already seen in diabetic retinopathy. Now we are finally coming to the third of the triads, the third part, which is the visual field. And this is the most interesting because this is something that we see. So what is the visual field? It's an island of vision in a sea of darkness. Yes, it's very poetic. It's because it is by Traquair, who was a Scottish, if I'm not mistaken, ophthalmologist who was also a poet. So this is your island of vision. Here we go, red outline. And this island has a hill, which is called the hill of vision. You have a hill because not every point on the retina has the same amount of quality of vision. And we have talked about this when we were discussing refractive errors way back. Well, not that far back. And at the top of the hill, you have the highest visual acuity, which is your fovea 6.6. And as you move away from the fovea and you get to the retinal periphery, your visual acuity is about 660. There is a point on the retina that does not see anything, which is called your physiologic blind spot, which corresponds to the position of the optic disc. You don't see anything here because there are no photoreceptors here. So this is a normal physiologic finding. This is called the physiological blind spot because it's normal. So this hill is actually quantifying your vision. It is giving numbers of values to it. From the best part, which is your fovea, all the way to the periphery, which has poor vision, and your position of your optic disc, which is seeing nothing, blind spot. Before we move on, let's just spare a moment to differentiate between visual field and visual acuity. And we used this sort of this picture when we were doing refractive errors, that your objects of interest right in front of you, their images fall on the fovea, and this part of the retina is testing using visual acuity. But the objects of images that are not your of your interest, i.e. not directly in front of you, their images fall on the area of the retina which is not the fovea, either the macular or the extramacular area, and that is why they don't have such good clarity. But this part of the retina is tested, or these bits of the retina is tested using visual fields, not visual acuity. And if I bring my hill of vision here, visual acuity corresponds to the peak, and then the visual field corresponds to the rest of the retina. And again, as we have talked about before, visual acuity in glaucoma is affected very late into the disease, because papillomacular bundle, which takes impulses from the fovea, are affected very late. It's the superior and inferior arcuate fibers that are affected early. Thus, your visual field is affected earlier, and thus visual field testing is more important, and thus the reason for talking about visual field, the third of our triad. These are the limitations of your visual field. Obviously, you can't see to the same amount all around because you have your nose and your brow and your cheek interfering. Temporal visual fields are the largest, about 100 degrees, because there are no bones here. So if you have a long nose, your visual field is sort of less. So naak lambi hona can be dangerous. That was in Urdu for a reason. I hope you all understood it. If you don't, perhaps someone can translate it for you. So how do we measure this visual field? Various ways. You have done this, I'm sure. Confrontation. It is a very crude method. It can pick up larger defects of long-standing glaucoma. Campimetry is no longer done. No longer practiced. Dead. Only reason I'm putting it here if somebody asks. This was how visual field testing in glaucoma originally started. It's also called the Jerem screen. The gold standard, the in standard, is called automated perimetry or automated visual field analysis, and this is done by an automated perimeter or automated visual field analyzer. We'll just look at this instrument in a little bit of detail. This is how it looks, and it shows lights here. We'll see how that happens, and you're supposed to look straight in, and every time you see that light going on, you're supposed to press this button so that the machine knows that you have seen it. Again, this is a very subjective test because you could fall asleep. And although these machines are really clever and they retest points, they also have a buzzer so they can alert you, but still it's subjective. It's dependent upon your ability to click or not click, or click too much or not click at all. So here's a rough demonstration of how these machines work. So this is a place where you can put a correcting lens in, so that if your vision is not 6/6 without correction, or you need some reading aid, you have this lens here for you. This right here at the back is not a hole in the lens. This is basically a camera that's tracking your eye movement. Remember, you're supposed to see straight, because if you move your eye, you will bring that light as your point of interest, because your fovea will be directed to it. And right now, we just want the visual field to be tested, not your fovea. So this camera right here is tracking your eye movements very carefully, seeing if you're moving your eye, and it can actually alert or even, mark how many times you had moved the eye. So correcting lens, camera, and this is a set of points, because you see your visual field has so many retinal elements and you can test an infinite number of points, and that will take such a long time. So the machine has certain pre-built tests, and the tests in glaucoma usually test a specific set number of points. And these are those points as represented in this circle here. And these are sort of location markers, so as to indicate which point on the retina we are testing by showing you a light on your visual field. We'll talk about these points in just these lines in just a bit, but they're basically degrees or angles from the fixation, which is right here, which is your fovea. So what it does is, if it wants to test this point right here, it will produce or turn on a light here, and it's waiting for you to press the button. If you press the button when you see the light, the machine will put a gray dot here, which will indicate yes, you saw the light. Let's check another point right here, and it will turn on a light, this point here, and for this testing this point here, the machine puts a light here. And assume that you don't press a button, you don't see it. So what the machine would do is, it would raise the intensity of the light. Now if you look at this dot carefully, this white dot right here, or this light spot where my cursor is, and the blue arrow is as well, my cursor might disappear, but this blue arrow won't. It will increase in intensity even in my animation. It might appear very subtle because the background is white, but believe me, it does. So look very carefully, very carefully. Here we go, the intensity increases, and it's increasing the intensity because it wants to know whether if I raise the illumination of this point, is the retina able to work? Because remember, it didn't at normal intensity. And if the patient is able to pick up a brighter than normal stimulus, it produces a darker shade of gray, telling, yeah, the patient could see, but I had to raise the stimulus in order for the patient to see, raise it beyond what normally the patient should be able to see. Let's test another point, this one right here, and for this the patient machine would turn a light on here, and the patient again does not press the button. So it raises the intensity, yes it does increase, and the patient still does not press the button until the point the machine has raised it to the maximum intensity. So this point the machine would say the patient is not able to see anything and produces a black spot here. So normal gray, relative dark gray, relative I mean relative to normal you needed to raise the intensity, and absolute would mean can't see anything. So it would do this for all the points, and it takes about 10 to 15 or 10 to 12 minutes in a person who is well trained to do one eye. So you can see how tiring it would be for the doctor or the technician who has to do 100 patients in a day. What to think of the poor machine who has to handle 100 patients in it. Anyways, besides the point. So remember I talked about these lines. We need some way of measuring where this point is on the retina, these points. And we do it by measuring the distances from the fovea. And since the retina is a curved structure, we can't measure distances in centimeters or meters. We measure them in degrees. The distances are angular. So if I'm testing this point here, and this line is passing through my fovea, this axis, I can simply measure the distance between these points from the fovea by measuring it in degrees. So these numbers right here, these lines indicate how much degrees am I away from the fovea, superiorly, inferiorly, nasally, and temporally. We'll see these numbers just in a bit. This is a printout that the machine gives you, and although the most important information you get is from these charts here, at an undergraduate level, we look at this bit, the grayscale image. Let's look at our grayscale image, and this is a normal grayscale image. First, let's see which eye this is. And I'm sure you can tell me which eye this is because we've talked about it before. This is where your blind spot, physiologic blind spot is, which is to the right of the fovea. So this is the right eye. These numbers are how much further are we away from the fovea, which is right here, 0 or fixation, 10 degrees, 20 degrees, 30 degrees, 10 degrees, 20 degrees, 30 degrees, 10, 20, 30, 10, 20, 30. I am sure you get the picture by now. The picture is right in front of you. How do we know which is nasal and which is temporal side? Superior and inferior are very easy to check. This is superior, this is inferior. Which is nasal, which is temporal? Very easy. The optic disc or the physiologic blind spot scotoma appears in the temporal field. So this is the temporal field. This is thus the nasal field. So these numbers are indicating the distance. These points right here, they appear as gray, so these are all normal. So these points were all tested by the machine. And this is your physiologic blind spot. It appears in the temporal field. And this is thus the visual field of the right eye because the blind spot is to the right of the fovea, as we just talked about a second ago. I'm going to put up the fields now. This is the superior and nasal field, inferior and nasal field, superior and temporal field, inferior and temporal field. So if you're ever confused which field is which, just look for where the physiologic blind spot is, and that's the temporal field. That's easy. Superior and inferior, I'm sure you could figure out. Superior is at the top, inferior is at the bottom. Let's look at visual field effects that we get when we do automated perimetry, and they are called scotomas. A scotoma is an area of no vision or low vision surrounded by an area of normal vision. The layman term for scotoma is a blind spot, like in physiologic blind spot, which is the layman equivalent of your physiologic scotoma, which equates to the position of your optic disc, which is also called the optic nerve head. There are two types of scotoma, and we have touched upon this when we were looking at how the machine works. One is called an absolute scotoma. An absolute scotoma was an area in which, irrespective of the level of illumination of your stimulus or your object, the patient wasn't able to see it. And this best example of this is your physiologic blind spot, because there are no photoreceptors here. The patient can't see anything here. It always produces an absolute scotoma. And in visual field analysis, it is indicated by black color, as we saw before. Relative scotomas are those that if you increase the brightness as compared to normal, the patient is able to see again. So the area is not totally non-seeing, but it is also not normally seeing. So it's called a relative scotoma, and they are indicated by various shades of gray. And the normal, as we've already talked about, is a light gray dot, which I have indicated as here, just as a comparison. Obviously, normal is not a defect. So this is again your superior and temporal field, inferior and temporal field, inferior and nasal field, superior and nasal field. The blind spot, physiologic blind spot, scotoma appears in the temporal field. That's one way of recognizing which field is which. I'm sure you can do superior and inferior. Before we move on and talk about glaucomatous field effects, it is really important to see how images are formed on the retina, which will infinitely aid in your understanding of these visual field effects and how we start correlating them to damage in the retina. Because remember, it is damage in the optic disc or the optic nerve head which is actually responsible for these visual field effects. And the optic disc or the optic nerve head is simply carrying information from the retina. So it's eventually the retina that decides which part is working or not in glaucoma and what would appear in a visual field that would mean that this part is not working. In effect, we need to see how images are formed on the retina so that we can correlate this to what we see in the visual field. And that is important because this process of refraction inverses the image that's formed on the retina. Very unfortunate, but it happens. Life is not all bed of roses. So this refraction vertically and horizontally inverts the image as it forms on the retina. So the superior half of the image falls on the inferior half of the retina, or is created in the inferior half of the retina, and the temporal half of the image appears in the nasal half of the retina. Amazing, isn't it? And that's just because of the process of refraction. And because refraction is basically a lot of convergence, and convex lenses, this is what convex lenses do. If you have done this experiment in school, they inverse horizontally and vertically. So I have this object which is made up of 4 squares of 4 colors. As you can see, the images on the retina are horizontally and vertically inversed. The yellow squares, which appears in the superior and temporal field, its image is formed in the inferior and nasal retinas. This is the nasal retina, this is the temporal retina. So something that was superior and temporal in your visual field, its image is in inferior and nasal retina. Simply something that's superior and nasal in your visual field, its image is formed in inferior and temporal retina. And something that was inferior and temporal in your visual fields, its image is formed in superior and nasal retina. And something that was in inferior and nasal visual field, its image is formed in superior and temporal retina. Everything is inverse. So why do we think the object is straight? Why isn't everything upside down to us? Well, because your visual pathway and your visual cortex makes this straight for us again. This is really important because this implies that if you see a scotoma in a superior visual field, the actual damage in the retina is inferior. And we'll just exemplify this more so that this thing is much more clearer, simply because it needs to be. This is a picture of the retina of the right eye, disc, right of fovea. This is a visual field of the right eye, the physiologic blind spot or the physiologic scotoma to the right of the fovea. So this is the superior and temporal retina. Inferior and temporal retina, superior nasal retina, inferior nasal retina. These are your fields which have been appropriately labeled. And as we decided before, the physiologic scotoma or the physiologic blind spot appears in the temporal field. Let's produce lesion 1, which is located in superior and temporal retina. Its corresponding defect in the visual field would appear in a location that's vertically and horizontally inverse, thus inferior and nasal retina. Lesion, matching scotoma. Lesion in superior and temporal retina, inferior and nasal field is where the scotoma is. If we have a lesion in superior and nasal retina, its corresponding scotoma would be in inferior and temporal field. If we have a lesion in inferior and temporal retina, its corresponding scotoma would be in, drum rolls, superior and nasal field. And finally, if you have a defect or a lesion in inferior and nasal retina, its corresponding scotoma would be in superior and temporal field. And because this physiologic blind spot is located in the nasal retina, its scotoma appears in the temporal field. Simple. But this simplicity only occurs if you know what's happening, and that's because images on the retina are inverted horizontally and vertically with respect to the objects. Let's talk about visual field effects in glaucoma, the reason we were here, the third of our triad. Why do we get visual field effects in glaucoma? And I'm sure you know the answer, but I'll just repeat it for you. We have already lost axons of ganglion cells, i.e. the nerve fiber layer in the rim of the optic disc, that eventually led to a loss of the ganglion cell, which led to a loss of visual signaling from that particular area. So that particular area became non-seeing and would generate a scotoma in your visual field. The problem is these scotomas appear once you have lost about 30 to 50% of your ganglion cells by the visual field checking standards that we have. So enough damage has already been done by the time first scotomas appear. And over that, these early scotomas that appear, they are so small that they're not visually significant. And they become, by the time they actually become symptomatic, the damage has been there for even years longer. So we have a double whammy of several years. Several years, initially, because visual field effects start appearing after several years of the initiation of the disease process, because we need to lose between 30 and 50% of ganglion cells before our machines can pick up these defects. The second whammy is that the earliest defects that you get are so small that the patient doesn't even notice it. So we are losing twice on time. And that is where OCT comes in, because if you use that as a screening tool, it's the best, because it can even pick up retinal nerve fiber layer loss within the rim of the optic disc not much before cupping is visually apparent. And cupping is apparent before visual field defects are apparent. And visual field defects take time to become symptomatic. To see how much time is passing, the disease is progressing, and we don't know about it because it's all painless. Thus, screening is so important. So where do we see these scotomas and how much of a scotoma do we see, i.e. the size, would depend upon the location and extent of the damage to the nerve fiber layer. And we know that the nerve fiber layer starts getting damaged in the superior and inferior rims of the optic nerve head or the optic disc, because this is the area where the fibers are most densely packed. So most of the damage that we see would be occurring in the area of the arcuate nerve fibers, and that is between 10 and 20 degrees of the visual field. This is called the Jerem's area. And as the disease progresses, we will start getting damage to papillomacular bundle as well as nasal fibers, and we'll see these. These are the blue zones on this diagram right here. The blue zone is sort of, it's written right here. The various types of defect that you see are called localized effect, nasal steps, and arcuate scotomas. And if we don't manage this disease, these scotomas will continue on and on and on, and will eventually lead in blindness. And management plans for glaucoma are designed around visual field analysis. Although visual field analysis is something that is only picking up defects once you have enough of a loss, but our management plans are still based around it. In the future, they would be based around OCTs, but right now we're dependent upon visual field analysis. So I moved the picture a little bit down so that you can see there was just blue and figure written there and nothing secret, which I was trying to hide from you. So let's see these defects as they appear in glaucoma. So this is a picture of the retina. These is the visual field, and these are all the points that are going to be tested by visual field analysis. This is your optic disc. This is the physiologic blind spot. It appears in the nasal retina, the optic disc. Its corresponding scotoma thus appears in the temporal field. So I'm going to take away this. I'm going to put my disc that we saw first in our discussion on cupping or retinal nerve fiber layer loss here, because we need to understand where these defects takes place in context of loss of neural tissue within the rim of the optic disc. Thus this picture is here. So the first effect we start seeing are between 10 and 20 degrees. So I've highlighted this 10 and 20 degree area with these two semicircular arcs, as you can see. And this is the area where the retina is damaged, this gray square or circle, and this is its corresponding scotoma. Since the damage is occurring in the inferior and nasal retina, its scotoma is going to be in the superior and temporal field. This is the earliest effect you see, and to get to this defect, it would take years. To this defect, from the start of the disease, it would take years, because to get this defect, you need 30 to 50% loss of your ganglion cells, as we just saw. And obviously, since we are now losing our neural tissue, we are going to see an increase in cupping. So the cup depth ratio is going to be greater than 3. It might already be greater than 3 before the appearance of this defect, because cupping precedes visual field defects, as we have talked about before. And what precedes cupping? Retinal nerve fiber layer loss that can be picked up by OCT. But we are not still using OCT as our benchmark for progression or management, because although our machines are getting better, they are probably still not as robust as visual fields. We'll get there in time, maybe another 5 or 6 years. So let's move forward. We get an area of signal loss here, and we get the corresponding scotoma here. And this is what a nasal step looks like. So this was called a localized scotoma in 10 to 20 degrees, and this is what a nasal step looks like. And this is where the damage is occurring. Inferior and temporal retina, and superior and nasal field is where we get the defect. And the cup depth ratio would increase even more, because the defects are increasing. That would mean that the neural damage within the rim of the optic disc is increasing. Let's move forward in time even more. And remember, this is a patient who is now not symptomatic up till here, because these defects are so much small as compared to your normal physiologic blind spot that the patient is unaware of them. He's still asymptomatic. Now let's put some more defects. More time has passed. And now we have gotten something called an arcuate scotoma. It's called an arcuate scotoma because it looks like an arc, and it has occurred because the damage is progressing in shape of an arc. And the reason that the damage progresses in shape of an arc is because of the orientation of these fibers, which is arc-like. So if the fibers are being lost in an arc-like pattern, the signal that they are receiving is also being lost in an arc-like pattern. Their scotomas are also arc-like, thus arcuate scotomas. So this is called a superior arcuate scotoma, simply because this is formed in the superior field. And obviously, because more time is passing, you will get scotomas in the other field as well. And again, these are localized scotomas within 10 to 20 degrees within the germs area. This is the point that the disease becomes symptomatic. And from the first scotoma that we saw, the localized scotoma in the previous slide, to this point can take up to 10 years or even more than that. So even the first scotoma appears when we had lost about 30 to 50% of the ganglion cells. So the disease has started even before that. See the double whammy of time, a large period in which we can't detect anything. First whammy. Second whammy is, okay, we have defects, but they are too small for the patient to notice. More time passes, and by the time patient is symptomatic, it's 10 years from the first scotoma that appeared. Probably longer since the disease process started. Thus the importance of screening. Let's move this disease forward in time, and eventually the scotoma would form in the other half of the field. We had a superior arcuate scotoma first. Now the damage has progressed to form an inferior arcuate scotoma, and the patient is left with a tunnel vision. It's called a tunnel vision because this entire ring between 10 and 20 degrees, the patient can't see anything. I'll show you how it appears to a patient, but he can't see anything. It's just like your physiologic blind spot. If you have tested your physiologic blind spot, it's not that there's a black spot there, you just stop seeing things there. I'll show you a picture that sort of demonstrates how this actually appears. And with this, we will also start getting other scotomas because the damage is progressing. So we get an inferior nasal scotoma, and obviously the cupping is getting even worse because the damage is increasing. Let's take this further in time. Now, since the disease has pretty much destroyed all of these arcuate fibers, it will start moving in to affect the nasal and papillomacular bundle. This is the point in time where your visual acuity will start getting affected. But remember, now we are more than 10 years into the disease. So visual acuity is not a good gauge. No, it is affected very late. And these are called paracentral scotomas because they are within 10 degrees of fixation. Fixation is again your fovea. And now your disc would start expanding horizontally because it's destroying your papillomacular bundle. And with it, your nasal fibers will also start getting damaged. But before that, let's see what would happen when all of your papillomacular bundle is gone and you would lose all your central vision. And this is the point where you are blind, legally blind, because you can't see anything from your foveal area. And obviously your nasal fibers are getting damaged, so you'll get these nasal scotomas. These are called wedge scotomas. because they look like wedges, temporal wedges. Nasal fibers destroyed would produce damage in nasal retina, which would obviously correspond to temporal visual field. Remember horizontal and vertical inversion? I'm sure you do. So now all of our rim is dead, and we are approaching a cupping of 1, and we are blind because we didn't take care of our disease. We'll see the factors that play a role into why glaucoma is such a conundrum. Even once it's diagnosed, once you have those scotomas that are symptomatic, even then it's difficult to manage this disease. And we'll talk about the reasons why that is. Progression of glaucomatous field defects, starting from no changes. The disease might already be there. Remember, we need 30 to 50% of ganglion cell loss before the visual field picks up anything. OCT may show retinal nerve fiber layer loss at this stage because that's the most sensitive. You may or may not be able to visually see cupping. Then we move on to a stage where the visual field defects start appearing. Now that we have lost 30 to 50% of our ganglion cells, we have moved 10 years into the disease, but these defects are so small that the patient has no symptoms. Now we're getting into a symptomatic stage where we start getting, as you can see, a superior germ scotoma, those localized scotomas between 10 and 20 degrees, together with a nasal step. Now we are seeing an arcuate scotoma, we are seeing an inferior arcuate scotoma developing, we get to a tunnel vision and blindness. It takes years to get from no change to asymptomatic, and then years to get from asymptomatic to symptomatic. This is my double whammy of time I keep talking about, and that is why I keep screaming about screening. This progression depends upon a lot of things. What age was this diagnosed? Did you have family history? How well is your IOP control, your race, and how regularly you were following up with? Remember, as long as you're not treating, the disease will progress. Even if you're treating, the disease can progress for many reasons. Some of them are very obvious, like the medication or the treatment not working, but there are other factors that we will talk about as well. One more thing, if you look at books, and I haven't mentioned it at all, they say that glaucomatous field defects are peripheral field defects, which is not really true because the periphery of the visual field is pretty far off, 90, 70, 60 degrees, and we are only testing the central 30 degrees. If you had noticed in all the pictures that we saw before, I'll just put one up for your benefit, we were only checking the central 30 degrees, and most of the glaucomatous defects were occurring in the 10 and 20 degree area. So what gives? Why do we call it peripheral field defects? We call it peripheral field defects because this is the periphery of the center. The central field is the central 10 degrees, and between 10 and 20 degrees is the periphery of the center. So this area is periphery of the center, not periphery of the field. So this all text that's written here that's boring is basically summarized in this diagram. Central visual field is central 10 degrees. The periphery is of the central visual field is between 10 and 30 degrees, of which 10 and 20 degrees is the one where glaucomatous field defects occur. So this entire text is summarized in this diagram. Don't want to read it, just look at this diagram. I'm sure you're not paying attention right now because you're getting bored. You're I don't know, World of Warcraft or PUBG or Fortnite or whatever is waiting for you. Candy Crush? That would be really sad. Anyways, this is our triad. IOP, which could be high or normal, with or without vascular dysregulation, leads to neural damage, which appears visually as cupping, leads to visual field defects. And this is what your glaucoma is in a nutshell. Now we are going to talk about, now that we know everything, things are going to be really simple and we are going to go really fast and we'll be done before you know it. We know what glaucoma is now. We just need to classify various types, and those are acquired or congenital. Acquired are of two types, in which the pressure is high or the pressure is normal. If the pressure is high, it is classified as juvenile, primary, or secondary. There is something called ocular hypertension, but this is not glaucoma. It's just here because the pressure is raised. And normal IOP is called normal tension or low tension glaucoma. Please remember this. Don't say Dr. Ali was telling us ocular hypertension is an example of raised IOP or open angle glaucoma. It says in his presentation. Or we saw this nice flow chart. Oh, but we forgot to read this sidebar. Read the sidebar. It's only here because the pressure is raised. This is not glaucoma. This is glaucoma suspect. Okay. Congenital glaucoma first. Congenital glaucoma is something that you are diagnosed from birth up till 2 years of age because the pressure on the eye might be felt up till this point in time. It's a generally bilateral disease, in a disease in which your eyeball is enlarged. That is why this disease is also called boophtalmos meaning ox-eyed, eye of an ox. It is of two types. It could be primary or secondary. A primary type exists when there is a genetically determined abnormality within the trabecular meshwork that it is not formed properly. It is in incomplete development, which produces a raised in IOP simply because the aqueous can't get out of the eye, and it does not occur in association with any other ocular or systemic anomalies. A secondary congenital glaucoma occurs when there is a definite ocular or systemic anomaly leading to decrease in flow of the aqueous through the trabecular meshwork. This could include intraocular inflammations, intraocular tumors, because of debris accumulation in the trabecular meshwork, which impede aqueous outflow. So if I can show this diagram to you, this is the trabecular meshwork, this is the Schlemm's canal, and this is the anterior chamber. And what would happen in primary congenital glaucoma is there's some abnormality within the trabecular meshwork that does not allow aqueous to drain into the canal of Schlemm. A secondary anomaly would be debris depositing within the trabecular meshwork that impedes flow of aqueous. Irrespective whether it's primary or secondary, the effects that you see on the eye are the same. You will have a baby who will have poor vision. He'll be very unhappy. He'll be crying. His eyes will be moving, always searching for light. And he won't be able to recognize familiar faces or objects, of which mother's face is the most important. Your IOP would rise and would have consequent effects on the eye, of which most important right now is optic disc cupping. But in addition to that, this high IOP in a child's eye, which is still malleable, would cause the eye to enlarge horizontally and vertically, which would mean that your corneal diameters would increase, your axial length would increase. So when you have this child, you want to measure his pressure in optic disc cupping, you would want to put him under anesthesia because he's not going to allow you to do it. Most of these children are at birth or within 2 years of age. They're not literate. They're not going to listen to you. So you need to put them under anesthesia. So when you're doing that, measure the pressure, measure corneal diameters, measure axial length and CD ratio. So you're doing everything which encompasses this disease. Your cornea is going to be hazy simply because the high pressure damages corneal endothelium, leading to edema. We discussed this pump when we were talking about cataract complications, and I'm sure you remember them. The corneal diameters and eyeball size is larger, which is basically boophtalmos, and this is high pressure causing increase in corneal diameters because the baby's eye is malleable, similar ditto for the axial length. These are the diameters at birth and what you would expect in this patient, and this is the length at birth and what you would expect in these patients. So this is how these children would appear. Large corneal diameters are apparent. See how the cornea is something that's all you see. In this patient, the baby on the right, sorry, you can't see anterior chamber details because the cornea is very hazy. Even in picture on the left, the cornea is hazy, but the details are somewhat visible. And the cornea becomes hazy because of hydration as the endothelium is damaged due to high pressure. All of these effects are because of high pressure. Management is generally surgical. Medical management is a stopgap measure. Stopgap solution until you can do surgery. And obviously, if you have a secondary underlying cause, you need to manage that first. If you have inflammation or tumors, those need to be managed before you talk about managing a secondary glaucoma, because maybe once you get rid of those factors, you won't need to manage glaucoma. So there are two ways of doing surgery. One is called direct angle surgery, which is the first choice, in which you are trying to open up the angle that never developed, or there was a secondary pathology that closed up the angle. The two procedures are goniotomy and trabeculotomy. I'll show you how it's done in just a bit. But goniotomy is done if you have some corneal clarity, like we saw in the baby on the left in the previous picture. You do trabeculotomy if the cornea is too hazy, like the baby on the right in the previous picture. If both of these procedures fail, you can do trabeculectomy. And the good part about this is that once you have the pressure under control by these procedures, the cupping may actually reverse. And that is simply because of resilience of the infantile optic disc neural tissue more than anything else that it reverses. Nobody has a very clear explanation as to why that is happening. So this is how we do goniotomy. We put obviously a gonio lens. We take a special blade and we just cut in the area of the trabecular meshwork to open up the maldeveloped or the incompletely developed trabecular meshwork. This is trabeculotomy, and obviously because you can't see anything inside the eye, you have a special instrument which is called the trabeculotome, It has these two prongs. One of the prongs you put in externally into the canal of Schlemm, and you move it into the anterior chamber, perforating the trabecular meshwork. The other prong is just telling you where you are, so that you have an external indicator of where you are going. If these two fail, you can do trabeculectomy. Trabeculectomy, we will talk again about management of acquired adult glaucomas, as well as more detail when we talk about angle closure, because it's more relevant there. This is reversal of cupping before surgery and after surgery, both right and left eyes. You can see a remarkable improvement in these set of pictures. So this is before and this is after. Don't read it left, right, before, after. It's up, down, left, before, after. So you can see the amount of cupping here and how much it has sort of improved after surgery. Now we'll do the raised or the acquired raised IOP glaucomas. Ocular hypertension is not glaucoma. It's just put here because the pressure is high. It's called glaucoma suspect. Don't blame Dr. Ali. So the first one is juvenile glaucoma. Juvenile glaucoma is a very rare and a very rapidly progressing glaucoma that usually starts in the juvenile age. It's a generally bilateral disease, and the myocilin gene or the myoc gene has been implicated in 10 to 20% of the cases. It is diagnosed beyond 2 years to adolescence. 18 years is the mean age, beyond 2 years, because by that age we have congenital glaucoma. And the presentation and features are very similar to primary open angle glaucoma. So just put those features here. We'll just do them in a bit. The management is similar as well. It just needs to be very aggressive, because this is a very aggressive type, but thankfully it's very rare. This is where the bulk or the majority of your patients would lie, the primary open angle glaucoma. Primary open angle glaucoma is the most common type of open angle glaucoma that you see in a clinic. And this results because there is an inherent abnormality in the trabecular meshwork that is producing increased resistance to aqueous outflow. This is again a generally a bilateral disease, and again the myoc gene is sort of involved in it. The same gene that was involved in juvenile glaucoma that codes for myocilin. The pressure in primary open angle glaucoma is raised. It's about 25 to 35 millimeters of mercury, and the patients are usually in their 40s when they present with this disease, i.e. when they become symptomatic. Since we really don't know how primary open angle glaucoma occurs, we have identified risk factors in addition to the genetic implications that we right now know of. Those risk factors, in addition to the IOP being high, include increasing age, African ancestry, myopic refractive error, family history, especially siblings, 7 to 10 greater chance of getting primary open angle glaucoma in first degree relatives, and the female gender. And this is what primary open angle glaucoma is. First, I'll show you how normal aqueous travels through the canal of Schlemm. And what happens in primary open angle glaucoma is that these spaces between the trabeculae and the trabecular meshwork are sort of reduced, which impedes flow of aqueous, thus causing a rise in intraocular pressure, which is then responsible for the changes of the glaucomatous disease process. Let's move on to secondary open angle glaucoma, which is again because of increased IOP. This time, there is an identifiable cause for the increased resistance to outflow through the trabecular meshwork. The age of presentation and laterality would actually depend upon the cause which is leading to the increased resistance. And they can be because of number of causes, including inflammation in anterior chamber, like uveitis, deposition in anterior chamber angle, like vitreous. We talked about this when we were talking about complications of cataract surgery. Tumor cells, blood cells can also deposit. Tumor cells, obviously secondary to your tumor. Blood cells, if you have trauma to the eye or you have new vessels which are bleeding in the anterior chamber, those blood cells can go into the trabecular meshwork and cause increased resistance, in addition to that same blood clotting and closing the angle. So both possibilities exist. We have something called pigmentary glaucoma, pseudoexfoliation. Pigmentary glaucoma is something that you see between 20 and 50 years, slightly younger demographic than primary open angle. Pseudoexfoliation usually in the 7th decade of life. Steroid intake and other. Steroid intake is really important. One of the reasons of developing glaucoma, something that can easily be avoided, is just unmonitored steroid intake. We'll just talk about it in a bit. So this is what secondary open angle is. This is normal aqueous outflow. So secondary open angle, something has deposited within the within the spaces of the trabecular meshwork, which is impeding aqueous outflow. And we have listed the things that can happen. I'll just go over them briefly. Inflammatory glaucoma is any condition within the eye which is causing inflammation, and deposition of inflammatory material within the trabecular meshwork causes increased resistance to outflow. We have talked about several of these conditions. Phacogenic uveitis, we talked about when you had a Mogaglian cataract. You can go back to cataract discussion, complications of an unoperated cataract to be more precise. And other types of anterior uveitis, we'll do anterior uveitis when we do the red eye. Vitreous in the anterior chamber, in addition to being deposited in the anterior chamber, it can also incite an inflammatory reaction, and inflammatory debris can deposit within the trabecular meshwork. Pigmentary glaucoma is a very specific condition which is associated with pigment dispersion syndrome. And this happens because your lens is rubbing against the iris, releasing pigment which deposits into the anterior chamber angle, which causes increased resistance to outflow. So it's seen in myopes, usually slightly younger demographic than primary open angle glaucoma. Pseudoexfoliation syndrome glaucoma, also called pseudoexfoliative glaucoma, is very interesting. It's usually seen in women in their 60s, more commonly in their 70s. And this is a systemic disease in which you have this amyloid-like material depositing in various places, including your pupil and trabecular meshwork, again causing increasing resistance to aqueous outflow. The other organ that this material affects, including your heart, which can cause hypertension or angina. It can also deposit within your ears, causing sensorineural hearing loss. Steroid intake. Oh, I hate this. I hate this because steroids, by various means, especially topical steroids, which people prescribe left, right, and center, unfortunately, ophthalmologists do it, probably knowingly that the patient is going to use it, and they don't explain how to use it. Family physicians do it all the time. And the reason steroids are prescribed so often in an eye, because they get rid of red eye, they get rid of this irritation that people get, that's mostly because of a dry eye process or a blepharitis process, which is inflammation of your lash, of your lid margin, which can easily be managed by other ways. But just because they want a quick resolution, they want to make the patient happy, they prescribe a steroid drop or an ointment. And what this steroid drop or an ointment can potentially do, it can increase expression of extracellular matrix proteins, glycosaminoglycans, and elastins in the trabecular meshwork, increasing resistance to aqueous outflow. This can be unilateral, but is generally bilateral. It can be unilateral if you're putting a drop in only in one eye. The IOP change is variable and is dependent upon the type of steroid you're using. I've listed some steroids and their ability to raise the pressure. Systemic steroids can also cause elevation by the same mechanisms, and not everyone who is taking steroids is going to get a rise in pressure. It is again genetically determined, and again the MYOC gene is implicated here. Talking about the others category, we've already talked about trauma in context of hemorrhages, which is the second one listed in others. We'll just briefly go over that. But trauma itself can also cause iridodialysis, which is separation of the iris from the ciliary body. If you remember the picture which was showed when we were talking about intraocular pressure in aqueous production, the iris inserts into the ciliary body. And enough trauma, blunt trauma to the eye can cause them to separate from one another. Iridodialysis, dialysis means to separate. Renal dialysis is done in case of renal failure because we are separating the waste product. Dialysis is to separate. And this separation can cause scarring in that area, which can impede aqueous outflow. Intraocular hemorrhage, as we've already said, in response to trauma or even neovascularization, can deposit blood cells into the trabecular meshwork, causing increased resistance. Tumor, again, tumor cells or debris associated with tumors can again deposit into the trabecular meshwork, causing a secondary glaucoma if the pressure is high enough for a long time. So all of these reasons, I'll just show you some pictures of them. This is that vitreous and anterior chamber. We have seen this picture before. So either by deposition or by inflammation, it can cause secondary glaucoma. This is pigmentary glaucoma. And as you can see, you have this pigment deposition on the cornea, which is called a Krukenberg spindle. And as the pigment is coming off the iris develops transillumination defects. You can actually start seeing through the iris. So you get a red reflex through the pupil normally. You also start getting a red reflex from the other area of the iris in addition to the pupil because there is no pigment there. This is called transillumination defect, which is shown by these white arrows, and the Krukenberg spindle is by this white outline and white arrow. Both of these are because of the release of pigment from the iris as it rubs against the lens, thus pigmentary glaucoma. This is pseudoexfoliation, and this is that white amyloid-like material that would eventually deposit in the trabecular meshwork, causing a rise in pressure and secondary glaucoma. This is not glaucoma. This is ocular hypertension. This is included in raised IOP category because the IOP is raised, but we do not have any evidence of glaucoma. Thus, just ocular hypertension. So this is, as I've just described, raised IOP without any evidence of cupping, retinal nerve fiber layer loss, visual field defects with an increase in intraocular pressure. So why even have this category? We have this category because every time the pressure rises, or every instance in which the pressure is a millimeter above normal, the chances of developing glaucomatous damage increases by 9%. And that is why it is important that these individuals who have ocular hypertension have frequent visual field or OCT analysis to ensure that the changes of glaucoma, if they do occur, are detected early so that we can start the management as early as possible in order to have the best possible visual outcome for your patient. There's another term called glaucoma suspect, which is used synonymously and interchangeably with ocular hypertension. The reason ocular hypertension is preferred because if you tell a patient you have glaucoma, or you are a patient of glaucoma suspect, he would think, I have glaucoma, and this would go on in his mind like a vicious cycle. I have glaucoma, my pressure is high, I will develop this, I will eventually go on and have all these visual problems. So the term ocular hypertension is preferred simply because it is a cushion to the patient, in the sense that you're telling him that you are at a risk of a disease, but you don't have the disease because we don't call it that disease, we don't call it glaucoma. So now that we are done with the high pressure category, we are moving on to the acquired glaucoma's normal IOP category. We only have one condition in this category, which is normal or low tension glaucoma. We are near the end of this classification system. So what is normal or low tension glaucoma? This is changes of glaucoma when the pressure is within the normal range. So you have retinal nerve fiber layer loss, cupping, visual field defects that you get when the pressure is normal. And this is theorized to occur because of vascular dysregulation. We have done the vascular dysregulation theory, in which we were saying that the nerve fibers within the optic disc head or the optic nerve get an ischemic attack or suffer from ischemia because of vascular dysregulation. And this vascular dysregulation is thought to be because of one of the theories. We'll now talk about normal tension glaucoma or low tension glaucoma, which is a subclassification of acquired glaucoma with normal levels of intraocular pressure. So this is defined as glaucomatous damage, which would be retinal nerve fiber layer loss, cupping with associated visual field changes at normal levels of intraocular pressure. This condition behaves exactly like primary open-angle glaucoma, with the exception that the pressure is within the normal levels or normal range. It is theorized to occur because of vascular dysregulation of nerve fibers in the optic disc, leading to their death. So your nerve fibers here are genetically predisposed to damage even at normal levels of IOP, and it is theorized that it is vascular dysregulation that's at fault. We have talked about the vascular dysregulation theory when we were talking about the etiology of retinal nerve fiber layer loss and cupping. Retinal nerve fiber layer loss and cupping. The risk factors here are Asian ancestry, especially Japanese ancestry. And something that's very interesting is that many of these individuals who have normal tension glaucoma have increased diastolic pressure, but they also have greater than normal nocturnal dips of their blood pressure. So their blood pressure falls below the regular nocturnal blood pressure, or what is the expected nocturnal blood pressure. And it is that fall below what's expected that's actually causing the damage to these retinal nerve fibers. which is basically explaining the vascular dysregulation. But again, these are theories more than established facts. And again, as I have said, that the features of this condition are very similar, or are those of primary acquired open angle glaucoma, except for the fact that the IOP is a normal range. The demographic is slightly different. Here, the individuals who have normal tension glaucoma likely to be 10 years older than those who have primary open angle glaucoma. Now, how do these patients present? All of them. We are doing it all in one because they present very similarly, with the exception that secondary glaucomas would have history and signs and symptoms of the disease that led to glaucoma. So all of these patients, as far as their glaucomatous damage is concerned, would present as gradual painless loss of visual field. Remember, visual acuity is affected very late into disease and is not a good predictor of anything in glaucoma. Is generally bilateral, can be asymmetrical. Truly unilateral is when you have something going wrong with one eye. Steroid in one eye, trauma in one eye, tumor in one eye, or inflammation in one eye, for example. There is a very long, considerable asymptomatic phase that we have talked about again and again, because the neural damage precedes the earliest visual field effects by a pretty long time, by years. And the initial disease is asymptomatic anyways because of the size and location of those scotomas and neural loss, which is very true for primary normal tension and secondary glaucomas associated with steroid intake. Simply because if you're taking steroids, you wouldn't know what's going on with your eye because you just keep on using them yourselves. Unmonitored is the word here. If you have a secondary glaucoma, if you have a cause for secondary glaucoma, open angle glaucoma, you're probably going to a doctor anyways. So if the doctor is good enough, he'll check your pressure and will tell you that this might lead to glaucoma. So this large asymptomatic phase is very true for primary open angle and normal tension when the patient is not going to the doctor for any reason, or even unmonitored steroid intake. Because you see, when you give a patient a steroid for blepharitis or dry eye, he will not come back to you. He will keep on using the steroid because it works. His eye is not painful or irritable. Not painful is a bad word. It's not irritable. It's not red anymore. He's happy. Why would he come to you? And he would continue using it because the doctor didn't tell him about the side effects of steroids. So thus there is a double whammy of time. The first whammy, and I've talked about this before, is it takes a lot of time before the first damage even becomes visible on visual fields. In fact, the earliest damage you can pick up is on OCT. And even by the time you pick up OCT damage, some damage has already been done. That's why you're picking it up. So all of that period is asymptomatic because nobody will go into a doctor if there is no symptoms. Thus, screening is so important. And the second whammy of time is, even if the disease process is started, the patient is not noticing anything because by the time the scotomas become big enough, another period of time has passed. Thus, the double whammy of time. And that's why screening is so important. And keep talking about screening again and again. And screening is here again. The age of presentation for primary open angle glaucoma is between 4th and 5th decades. There are exceptions which are listed here, and the age difference is from primary open angle. Juvenile is 18 years normally. Normal tension is 10 years older than this. Pseudoexfoliation is 7 decades of life or more. And secondary glaucoma would depend upon the cause of secondary glaucoma. But since by far the majority of your patients are going to be of primary open angle glaucoma, as we've already said, this is the age that they will usually present to you with. So if you're getting a patient as a family physician who is of this age, and you take a good history and you find out those risk factors that we were talking about, please have a look at the patient's fundus, buy an ophthalmoscope as a family physician. If you don't want to do it, send him to an ophthalmologist, a friend ophthalmologist who would probably give them a discount, or a public sector hospital, so that at least you are completing your end of the job. You're appropriately communicating and explaining to the patient what can go wrong. The symptoms that your patient is going to present with are those regarding the visual field, because remember, visual acuity is affected very late into the disease. So the most common type of symptoms they would have is either they won't be able to see cars as they are overtaking them, or people would bump into them as they're walking simply because they can't see the cars or the people. The signs you would see are intraocular pressure, which may be normal, may be raised. RNFL loss, or retinal nerve fiber layer loss. This would be visible on OCT before visually noticeable cupping and visual field effects. Remember, this is where the role of OCT and upcoming role of OCT is most prominent and most promising because it allows for earlier screening. Optic disc cupping is again something important because this appears before visual field effects. So please get an ophthalmoscope. As I said before, it is good for screening your patients. You know, your patients would like you more. You'd get more patients. You would make more money. And visual field effects. And unfortunately, or fortunately, depending how you look at it, today the management protocol for glaucoma is around the visual field. So visual field is still important in spite of the fact that it appears after cupping and way after the retinal nerve fiber layer loss is picked up by OCT, but still this is the sort of the gold standard for monitoring management. Secondary glaucomas would obviously have signs and symptoms of the specific entities causing the secondary glaucoma. They are listed here. We have talked about them before as well. RAPD in a setting of glaucoma is uncommon. It is uncommon because glaucoma is a bilateral disease. You do have unilateral causes of glaucoma, but they aren't the most common. And although it's an asymmetrical disease, it's still bilateral. So it's not the disease in which RAPD is something that I would put at the top of the list in signs that I can see. But it still can be there in a bilateral asymmetric disease. It will not be there in a symmetric disease. It can be there even if your visual acuity is 6.6, simply because the RAPD response is dependent upon how much of the retina is damaged, not which part of the retina is damaged, because pupillary responses are mass retina responses. More detail in the pupillary examination clinical skill video, but I think this is enough. Right now, it is enough to say that your patient might be 6.6 and still have an RAPD in a setting of glaucoma, simply because enough of the retina is damaged, even if your central 10 degrees are spared. So this is how cupping appears. We've already talked about cupping, and this is a picture that I'd like you to see. This is a normal visual field, and this is a glaucomatous visual field, both right eyes. So both of these are at a stop sign, and miraculously they have the same car in front of them. Let's see what the patient who has a glaucomatous field can't see, and this is not a zoomed in picture, believe me. The first thing he can't see is the stop sign. So he's got a scotoma here. The second thing he can't see is the car on this side, so he's got a scotoma here. The third thing he can't see is the part of his dash, so he's got a scotoma here as well. And if you look carefully, he can't even see the top of the tree here, and he can't see the top of the roof here, so he's got a scotoma here as well. So if we translate what he can't see in his visual area to a visual field analysis, I'm just putting some central vision parameters down here so you can see that his central vision is right now pretty much intact. These are the areas he can't see, which corresponds to this. This patient is looking through a tunnel. And imagine the damage he would do. He would just run across here. He wouldn't see his car. He could get hit by this car, a car coming from this side, especially if he was the car in front, right, this guy, rather than standing behind him. Very dangerous. And this, unfortunately, is a disease which presents so late when actually a patient has been in an accident, because that's what made him realize he couldn't see the car. And that is why I keep stressing about screening, screening, screening. So how do we manage glaucomas? Why does Dr. Ali go on and on about screening and glaucoma all the time? Well, silly, because glaucoma is a silent killer. No pain or symptoms noticeable for years. It takes years for the damage to manifest as observable defects on visual field, and years more before the patient is symptomatic. The best way to screen is to detect very early neural loss by doing OCTs of the optic disc, but they're expensive and not widely available in our country. Thus, visual fields measuring CDR or IOP can serve as cheaper alternatives, but unless you screen, your patients are going to present late and they're going to have worse visual outcomes as compared to those who were screened earlier and would have better vision in the long run. That's why he keeps on going about screening all the time. So after that brief interlude, we are back and we are managing our patients now. And though we've been saying that intraocular pressure is just a risk factor, it is the only controllable factor that we know of that can actually prevent further damage. Management is thus targeted towards ensuring that whatever level of neurological damage the patient has presented with, it stays there. Remember, this is neurological damage, it's irreversible in nature. And this management is generally lifelong. There are certain types of secondary glaucomas in which if you remove the inciting factor, you successfully manage the disease, but generally the treatment for glaucoma is lifelong. And non-adherence, as I've talked about before, is a real issue. In glaucoma. Between 30 and 70% of your patients will at some point in time in their treatment will experience non-adherence. Lifelong therapy, multiple drugs, multiple bottles that have to be used, the cost associated, other comorbidities that the patient might have are all factors that play a role in non-adherence. There's a very special type of non-adherence called white coat compliance, and that is adherence that rises that closer to a doctor's appointment and then falls off. So the patient just subconsciously or consciously becomes more careful about his treatment, and is very religiously using his treatment close to the doctor's appointment, and then just sort of forgets about it. There are many causes of non-adherence: cost of the treatment, patient's understanding of the disease, comorbidity that the patient might have, availability of drugs is a real issue in our country, and patient education, i.e. the doctor didn't explain, the patient did not want to believe what the doctor was saying, and the doctor wasn't generally using terminology, or wasn't aware that the patient wasn't understanding what he was saying. That is why it is so essential and important that you ask the patient, what have you understood by what I have said, and how would you take the treatment, so that what you have said is passed on to the patient. So what protocol is followed? The first and the most important thing is to set a target pressure. A target pressure is a pressure which is very unique to every patient, and is the pressure at which you see no further damage. And how do we see that? As I've talked about before, right now all our protocols are designed around visual fields. So the protocol states that you have stable visual fields, i.e. no new scotomas developing or no increase in size of existing scotomas on repeated testing. You need to get 6 fields done in 2 years in order to ensure that whatever treatment that you have started is really able to stop the progression. So 6 fields in 2 years after starting your treatment. What treatment you start, how we do, we'll just talk about it. In normal tension glaucoma, although your pressure is normal, you need to bring it down even further to set its target pressure. And once you have determined your target pressure, you need to ensure that that target pressure is maintained and works for that patient. Sometimes what happens is that your IOP starts drifting because of tachyphylaxis or tolerance, so the pressure slowly starts rising. So your target pressure is no longer maintained. Or even if your target pressure is maintained, i.e. is the same as when you started the treatment, but the damage increases anyway, so you need to reset your target pressure. And you can only do that if you continuously assess the patient by visual fields after the target pressure is achieved. But those visual fields are not very frequent. They are once or twice a year. And once you start seeing that your target pressure is no longer maintained, you have to start the cycle again, i.e. You get your 6 stable fields in 2 years to ensure that this target pressure that you have set now is a target pressure. And obviously, any secondary cause that you see, you have to manage appropriately before you start setting a target pressure, because the high pressure might altogether go away and the disease progression stops automatically. So what are the modalities that are available to us? Well, it's listed in front of you: medical, lasers, something called MIGS, minimally or microinvasive glaucoma surgery. This is something that's really catching on these days. And then traditional surgery, which is called trabeculectomy. The good part is you can fall back on medical management after doing any of the procedures listed at 2, 3, and 4. So medical management, the drugs work in 2 ways. Either they reduce production or increase drainage. These are the drugs that reduce production and increase drainage. The only 2 things that I would like to mention here is prostaglandin analogs are first choice, first line, no questions. Irrespective of what anything says, unless contraindicated, prostaglandin analog is the first choice drug. You'll see the reasons in a bit, and it achieves its maximal effect between 3 and 5 weeks of starting the treatment. Parasympathomimetic drugs, pilocarpine, is not a usual prescription drug. it is not usually prescribed because it can actually lead to angle closure and severe headaches because it causes pupillary spasm because it's a parasympathomimetic drug. We'll talk a little bit more about pilocarpine and its importance when we talk about angle closure. The drugs that decrease productions are beta blockers, alpha agonists, and carbonic anhydrase inhibitors. Alpha agonists are said to be neuroprotective. Remember, it's neural loss that leads to all the issues with glaucoma, the loss of retinal nerve fiber layers. And these are said to be neuroprotective, but to what extent is this neuroprotection really working is difficult to say. So these are the drugs. This is their IOP reduction ability. These are the dose, and these are their major side effects. Prostaglandins are first choice, no questions. All of these are topical. Carbonic anhydrase are also available in tablet form, and can also be used at times. So as you can see, minimal dose, maximum IOP reduction makes prostaglandin analogs the choice. Beta blockers are good, and at one time before prostaglandins were available, and since prostaglandins are now available as generic brands, since the very first prostaglandins that was used was developed, very first prostaglandin that was used was developed in late 1970s, I think 77 or 78. Its patent, I think, has expired, so generics are available, and low-cost alternatives which work just as well are available. So use that. It has low dosing. It has, in fact, the minimal dosing of all of these agents. HAs, once evening dose, has the maximum ability to reduce the pressure. And unlike beta blockers, which can be given to patients who have asthma or cardiac conduction defects because, they can cause shortness of breath and reduce pulse rate, prostaglandins generally are well tolerated. They do cause a little bit of an allergy and itching and burning because they are pro-inflammatory agents. But once you start putting them, the patient adapts to them pretty quickly. So this is how a medical protocol starts. You remove any obvious cause of a secondary glaucoma. Open angle glaucoma is indicated. Start with one drug, prostaglandin analog, and you see if this is able to achieve a target pressure, 6 stable visual fields in 2 years. If a target pressure can't be achieved, you add another acceptable drug which does not have the, acceptable would mean no side effects. And the drugs do have synergistic action, so that is good. And you keep on monitoring, as I've said before, 6 to 12 months once you have achieved your target pressure. At any time, if you see the damage is increasing by new scotomas or increasing defects, already existing defects, size of those defects, you reset your target pressure, as we've already discussed before. And this reset would imply that you now again do 6 visual fields over 2 years to make sure that the target pressure is able to keep a stable visual field. You can change one drug type with another type, for example, one beta blocker with another type of beta blocker, and that works sometimes. And tachyphylaxis and tolerance, as I have said, are factors that are responsible for efficacy of the treatment. Once you are done with medical management and no drugs are left, you can try lasers, stents, surgical options, and you can come back to medicines after those options to see if they can reduce intraocular pressure further. Laser trabeculoplasty is our option 2. In many countries, it's option 1. In our countries, option 2A, it's not that widely available, and you don't have a lot of expertise in use of laser trabeculoplasty. Number 3, our patient follow-up is really poor. Laser trabeculoplasty works by making the openings in the trabecular meshwork larger. You can use YAG laser or argon laser to create larger openings. We have talked about both of these lasers before in context of cataract and diabetic retinopathy. And the good part is that if done properly and if done well, you can have 5 years of stability, i.e. your visual fields are stable without the use of drugs, if you're using it as first line treatment in addition to in place of medications. The problem is that trabecular meshwork is a living tissue, and if you poke holes in it, it will heal, and those spaces will be smaller than you started with prior to doing laser. So that drugs don't work really well as second line after you have done trabeculoplasty, because your spaces are narrower than you started off with. So as I said, evidence does dictate that you can use it as number 1 instead of drugs, but in our country, usually it's drugs then laser. This is how laser is done. So you use a gonioscopic lens, you focus your laser and you just fire away, and you know that your laser has created a hole once you see a little bit of a bubble in your aqueous humor, which tells you that the laser has done its work. Let's see how this is done. I'll show you a little video. This is where the laser is focused. As soon as it is fired, you see these little bubbles here. And these bubbles are telling you, yeah, that laser has created its effect. Here we go. Here, nice bubbles. There we go, more bubbles. So these bubbles are indicative that, yeah, your laser has acted on trabecular meshwork and has sort of done its job. Then we have MIGS, minimally invasive or microinvasive glaucoma surgery, something that's really up and coming. One of the ways of using MIGS is stents. It's not the only way. Stents are specialized devices which enhance outflow of the trabecular, of the aqueous humor to the canal of Schlemm. They sort of bypass your trabecular meshwork because they are inserted into the canal of Schlemm through the trabecular meshwork. It's like cardiac stents. They are enhancing the way for aqueous to move out of the eye. And they're usually indicated if your patient has poor control of glaucoma on medication. So this is one example. It's called an eye stent. It's not made by the Fruity company. And it's inserted into the canal of Schlemm internally. I'll show you a little video how that is done. So you have a gonioscopic lens. This is your stent, this thing in red, and this is the injector. This is Dr. Shannon Wong, and he's going to go in through the trabecular meshwork. It looks easy. These things take time to, master, not mastermind. So this is going in through the trabecular meshwork into the canal of Schlemm, and once you're sure you're inside of it, you just let go of the injector. You press a plunger on the injector and just injects it into the canal of Schlemm. And a little bit of blood will come out from the canal of Schlemm, which will tell you, yeah, this is in the right place. You can use more than one stent in one patient. Usually 2 are applied. So you go in from the trabecular meshwork into the canal of Schlemm, let go of the stent from the injector, and a little bit of blood coming out tells you, yeah, your injector is in place. Your stent is in place. Injector can't be in place. Trabeculectomy. So this is a bypass surgery or a filtration surgery in which you create an alternate passage for the aqueous to get out of the eye by cutting away a piece of trabecular meshwork. We'll do a lot more and talk a lot more about trabeculectomy, how it is done, what's the procedure like, complications, when we talk about angle closure, because it's more relevant there. And this is performed in patients who have poor control on medication, have also already had laser trabeculoplasty, or even have had stent insertion or mixed procedure already done. So I created this rather beautiful flowchart for managing glaucoma, if I may say so myself. And it starts off by establishing a diagnosis, which is based on visual fields, cup disc ratio, IOP. I've also included retinal nerve fiber layer as well, because OCTs have allowed us to detect very early glaucomatous damage even before CD ratio changes or visual field effects appear. So I've put it here. Although protocols do not widely exist yet that allow you to base your management off them, still it is something that can be done and is really promising, especially with regards to catching the disease early and managing it at an earlier stage so that the patient has better quality of life overall. So once you have your diagnosis, you start your treatment. We are going to start with a prostaglandin analog, unless it's contraindicated, so you can fall back to one of the other drugs. And we are going to set our target pressure. And the target IOP is again 6 visual fields, which is done in 2 years, which show no progression. These can be done at 3 monthly interval or what interval, but you need 6 fields in 2 years. If you get that static visual field, no progression, you continue your treatment, keep on monitoring 6 to 12 months to ensure that, yes, that pressure is still something that keeps the visual field static. And as long as they are static, you keep on moving in this cycle and you are happy and your patient is happy. But if the visual field were worsening, in spite of the fact of starting this one drug and you couldn't reach a target pressure, you add another drug and you review your visual field and IOP. IOP is again to just to set a target pressure, and this review is again 6 visual fields in 2 years with no progression. And if they become static, you fall onto the left pathway. If it's worsening, keep on adding drugs and keep on repeating this. If at any time a static visual field starts worsening, it could be because of tachyphylaxis, it could be because of tolerance, it could be just because at the same pressure you have more damage. So we need to reset our target pressure so we add another drug. and we follow the right pathway now. So we review again 6 visual fields in 2 years and see if we achieve a static field or not. If we do, we come back to the left path. Or you reach a point where you just run out of drugs. At this point in time, you can do one of these procedures: laser, stents, or trabeculectomy. Not all at the same time, obviously. Whatever expertise and equipment you have, you select according to your circumstances. And then you can also go back to drugs if required. What is important here is this R, and this R is review, and this review is the visual field review that you must be doing in order to make sure that whatever you have done after you have no more drugs left, these procedures, they are able to achieve a target pressure, and that is do 6 visual fields in 2 years. And after these procedures, if these visual fields do really show no progression, you still keep doing visual fields 6 to 12 monthly, after every 6 to 12 months, i.e. 1 or 2 visual fields, to make sure that the target pressure is doing its job. So it doesn't mean that the protocols you have established and those protocols continue to continue to be enforced even after you have done these procedures when you run out of medical management or drugs to manage glaucoma. This case is just to highlight and emphasize the importance of target pressure. We have a 55-year-old male with a pressure of 35 in both eyes, 35 millimeters of mercury. OU means ocular units in both eyes, a cup disc ratio of 0.6 in both eyes, and 3 localized scotomas in both visual fields. This is, and the patient doesn't basically complain of anything else, no redness, no other cause of secondary open angle glaucoma. So we establish a diagnosis of primary open angle glaucoma, start a prostaglandin analog. We do for the next 2 years 6 visual fields, and we see that the pressure is 24 during that time, CD ratio 0.6, and a visual field is static. That means this pressure of 24 is a target pressure for our patient. At 30 months, pressure is slightly lower, but our visual field is static very good. At 36 months, the pressure is lower than what the target pressure was before, but we have one new scotoma. That means we need to reset our target pressure, not because our drug stopped working, simply because the damage increased, because the pressure is within the target pressure range. So we add a new drug, and we do again 2 years, 6 visual field review, and as long as they are static, our new target pressure is 20 millimeters of mercury. And then at 90, we develop an arcuate scotoma. So this means that this time now, the pressure is higher than our target pressure. So it's more than likely that tachyphylaxis or tolerance has caused this change right here. The first change was because of the fact that the target pressure was still maintained, but the damage was increasing. So the target pressure could no longer sustain the nerve fiber layer. So we needed to lower the pressure even more to determine a new target pressure. Thus, we added a beta blocker. At 90 months, the pressure is higher than before. So this means that the pressure has slowly drifted upwards from our new target pressure, which was 20. So this is tachyphylaxis or tolerance. I'm going to sort of, it's one of those processes because this is pretty long term now. And I'm sure you know of the two, which is it, tolerance or tachyphylaxis. The answer will come up before the end. Anyways, we add another drug and we do our usual 2 year 6 visual field review. And as long as those are static, we know that this is our established target pressure now. So in summary, treatment is modified only when target pressure is no longer maintained. And target pressure is no longer maintained when the damage increases at target pressure, like that happened the first time around, between 30-month and 36-month review, when the pressure at 36 months was lower than the established target pressure, but the damage increased. So we knew that the damage, this fulfills the first condition, damage occurring at target IOP. So we need to reset or find out a new target IOP, which we determined was 20 millimeters of mercury, right here. And the second one that happened was at 90 months was that we could no longer maintain our target IOP. So this is, those short or long-term issues that we talked about before, or the patient simply not using the drug or quality of drug or other factors. But in effect, every time you change your treatment, you change it on the basis of whether the IOP you have set, i.e. the target pressure, is effective or not in keeping the visual field stable. Thus the importance of doing visual fields once or twice a year even after you have established a target pressure by doing those 6 visual fields in 2 years. I know it's a huge deal for your patients, but it is something that's essential because this disease is silent and this disease does kill vision. So these are various low vision aids. These are used in cases of extreme levels of low vision. Finally, the last slide. We are at the end of the theme and at the end of the topic, or at the end of the topic and the end of the theme. At the end of every major theme that we'll do, gradual painless loss of vision, the red eye, and sudden painless loss of vision, we will present you with a table. So this is a sort of a tradition. And the purpose of this table is to ensure that you can gauge your learning in the sense that these tables have all the diseases that encompass a certain theme, and it allows or shows you differentiating points based on history and examination findings and easy findings, not something that you would need an OCT for. So this is more for your learning than anything else. So the PowerPoint equivalent of this video discussion is so much more useful because you can uncover, recover at your own leisurely pace. I'll just uncover them all so that you can review them here and then use them at your own leisurely pace as you see fit. This is the end of our first theme. If you're following a 2-week clerkship, this is one of the 3 themes you will do. If you're following the entire 4 weeks, this is one of the 5 themes that we will be covering with you. Thank you very much for your time and attention, and I will see you in your next video discussion.